And it was around this fungus. Well, they isolated that fungus was penicillin. And then he published a paper on it, but he couldn't produce it in large quantities. Later, Howard Florey at Oxford, almost about 10 years later, he assembled a team at Oxford to try and mass produce this. But because of the war, they couldn't mass produce this. So then they reached out to a Charles Tom in Peoria, Illinois, in the US. He was able to isolate a strain of fungus, a strain of mold on a cantaloupe that produced a lot of penicillin, and was then able to mass produce it. So by the end of the war, they were able to supply penicillin to all the Allied forces. So it was this chance event. What he saw was, here's a petri dish with Staphylococcus. I'm looking at it. Nothing's growing around it. I don't necessarily understand why that is, but I'm not going to cast that aside. I just know it's that way. So then he started working backwards to figure it out. See how that works? So that's a good way kind of to solve problems sometimes in medicine. So, but where's it bad? And I was like, how do I use an example to talk about how this is bad? And I thought about energy drinks, right? I have young adult children. They like to drink energy drinks. You guys probably don't drink energy drinks, but energy drinks back in the 30s were pretty popular, and strychnine was used in energy drinks. Strychnine it's a poison, right? It was a rat poison. It's derived from this plant in India. And there's even a case, medical students would use it to study for exams and cramming for exams. And a medical student actually survived almost overdosing on this energy drink of strychnine. And he talked about how after he drank this energy drink, he drank a little bit too much. He couldn't sit down. Then he started having muscle spasms. Then he went unconscious. He ended up waking up the next morning to write about it. But the observation was this, that strychnine in small amounts operates as a short-term stimulant similar to caffeine. They used it in Olympic athletes. Hitler used it. But why is it? What was lacking? This observation, it seems to really stimulate you, but it was an understanding of what's occurring. Well, what occurs with strychnine? Here's a alpha motor neuron cell that stimulates a muscle, but there's this other cell that's called a Renshaw cell, and this Renshaw cell will produce glycine. And glycine, if you look down here, glycine comes down here and it acts as an inhibitor. So it turns off the motor neuron. You need that glycine. If you don't have that glycine, then all your muscles will start contracting. What strychnine does is it fits in that glycine receptor, but it doesn't stimulate it. So then initially when you get it in small doses, you're hyperexcitable. I mean, just the slightest stimuli will just get you jumping and moving. But if you get it in a dose large enough, what will happen is this or this. We've probably all made that face before tests, but that then will eventually result in respiratory failure and death. It's very painful. So this is an example of the principle, and several people died of this. This is an example of this principle gone bad, right? So yeah, I cannot imagine studying for a test like this. When is it irrational? Now, nobody probably does this, but behavior in sports among both athletes and fans is driven by a host of irrational psychological and social associations. Superstitious behavior. Fans may develop rituals or superstitions such as wearing a specific jersey or sitting in the same spot, believing that these actions can actually casually influence the game's outcome, right? They had this observation. Every time I was here watching this game, things seemed to go well, or when I was wearing this jersey, things seemed to go well, right? Therefore, it must influence the outcome of this game. And studies show that highly invested fans who feel a lack of control over the game are more likely to engage in these behaviors. And I would also tell you, highly invested nervous surgeons can engage in this behavior in the operating room when it comes to the way they set things up. You'll see it in medicine too. There's no reason for it. There's no science behind it. But they're just behaviors we engage in. These are things we just do. Well, So let's talk about how we got here, because one of the things the medical students I work with at the last time we got together said, explain to me exactly what the African Trauma Initiative is and how we got here. So we're going to go through that. And how we got here is myself and others trying to apply this principle of, I don't understand why things are the way they are, but I can tell you the way they are and something needs to change. So I started doing international work after I got in practice, traveling to Romania. This is my first group that I traveled with. Here we are in Bucharest. We took a train from Bucharest to this small town in the northeastern part of the country, right next to Ukraine. It's mostly a rural type community. Here we are getting off the train. Beautiful little town. Some of our Lexi just got back from there. And Annie just got back from there. Yeah. And this is Bodashan. It's not a huge town. The population here, here's our hospital. It's about 90,000. I've got that. Let me back up just a little bit. So yeah, here's the hospital. That's about an 8-9-story hospital for this town of about 90,000 in the surrounding area. When we got there, you can see it was very busy. I mean, we arrived. This is what she's no longer my nurse, but this was one of my nurses, and she's there bringing in patients. Busy, really busy. It's a trauma center. They asked me to come there to teach how to do certain types of trauma, orthopedic trauma surgery. So I got there, and it was kind of what I was expecting. Very busy, limited resources. I worked with this gentleman here. This is their operating room. They're using this drill. This is his son. Two of the probably most influential people on my surgical career, I would say, honestly, in terms of getting me able to think outside the American box when it comes to performing medicine and surgery. So there was that. But then as I developed my international work, I was asked to go to Ethiopia. Now here's the skyline of Ethiopia, Addis Ababa. This is the skyline of Addis Ababa in Ethiopia. Their capital city. Population's about 5,957,000 as of 2025. Now you remember what the trauma center looked like in Romania. It was about 8 stories tall, right? You saw it. But I want you to look at this. I want you to look at the skyline, and I want you to look at their trauma center. That's about 4 stories tall. And actually what it is it's just an old hotel that they took and they turned into their trauma center. But I want you to look at that skyline. Compare that skyline to what was in Bodashan, this rural area. So a rural area in Europe has a better trauma center than this huge city, metropolitan area in Africa. It's interesting. You know, I wasn't connecting the dots though. I expected to see, something larger. I really never did. This is their trauma center in Addis Ababa. And I had pictures of patients in Romania, but I will tell you what I saw in Ethiopia. You saw one of the gentlemen talking in that whole discussion of wisdom about principles and human dignity. I took no pictures of people there because to do so I felt would be to rob them of their dignity because they were in such dire straits. You have people arriving with illnesses that are life-threatening and they're sent home. Well, I mean, you've got a city of almost 6 million people and their trauma center is a old hotel, 4 stories tall. Why? It didn't make sense. Now, I'm going to show you 3 very influential men. This is Dr. Zagina, one of the first orthopedic surgeons in Ethiopia. And this is Dr. Solomon, one of our first fellows. This is Mamo, Dr. Mamo. And I went and I worked with these 3 men. And what they told me was, they said, we don't need more Americans coming or Europeans coming to Africa to operate. Just teach us how to do this and we'll take care of it ourselves. That's what led to this. So it was kind of that, it was that meeting of the minds. Got along very well. We developed this fellowship. It took some time, a lot of work with the Office of International Programs, but it was with this group of 3 men that this started. And then we started using the muscle power of the university. I mean, the university, what do we have here? We've got lots. We've got a school of engineering. We've got a school of architecture. We've got a school of business. There's lots of things we have to do here. School of medicine, school of nursing. So one of the people I reached out to was Matt Jacobson here, who's a professor in film and media. And then you'll see Bacher, who was one of his students at the time. And I said, this is a problem. I didn't understand exactly why it was a problem, but I said, we need to raise awareness about this. If we're going to reverse this, I can just tell you this. There's a lot of unnecessary death occurring in Africa. I just know that. I know that. I don't know why it is, but we need to raise awareness about it, right? And so he jumped on board. This is Abby. He and Dr. Solomon were some of our first fellows. This is our team here when we went there, and Abbott Hospital graciously hosted us, and we worked there, and it was like sun up to sundown, working in the hospital, filming, and then at night kind of going over everything that we had observed during the day and trying to put it together to make something that people would understand. So if you think about it, when you're putting something together like this, if you're going to put together a documentary, and if you're going to do research, you have to understand something. So we're trying to understand something. And I want to open your mind to the things that we discovered. So we just started looking into, look, there's all these people that we see that are unnecessarily dying or becoming disabled as a result of trauma. How does that compare to other pathologies? And if you look, injuries, they kill more people than HIV, malaria, and TB combined right now, currently, but not as much as ischemic heart disease and cancer. But an interesting fact about this is 93% of the deaths from trauma, 93%, 9 out of 10, occur in low to middle income countries. We don't see it. How often do you hear somebody dying of trauma? It doesn't happen here. We have a well-established trauma system, but not there. 93% of the world's trauma deaths, they're occurring in low to middle income countries. Now, there's a reason for this. In addition, it's the major cause of disability in low to middle income countries. This is a clear disparity, right? If you're somebody who cares about justice and equity and fairness, this is not equitable. I say it almost every talk, but do children in Africa matter as much as our children here? I think everybody would agree with that. You're here, you're in medicine, you're in this field because you care about people and you want to do good. You want to treat people well, right? That's not fair. It's not equitable. So then we started looking at, well, what is it that's killing people? Can we just get a handle on what's killing people? What's disabling people? This is just a pie chart. It shows, if you look at it, the majority of the deaths due to trauma are due to road traffic accidents, conflict-related violence, whether interpersonal or war, falls, and a lot of these are related to work-related injuries, and then self-harm. So those are the major killers. So then we started honing in on, well, how much trauma is occurring in Africa? Well, if you look throughout the world, the highest concentration of trauma occurs in Africa. Why? Why is that? Are they clumsy? Are they falling all over the place? Are they the worst drivers? Is this it? Are they just bad drivers? It's not that, right? That's not what it is. I showed this at the last lecture, but this is a heat map from the World Health Organization, and it just shows the concentration, of mortality that occurs as a result of road traffic accidents. The darker the green, the higher the concentration. Look where most of that's concentrated at. Road traffic mortality, most of it's concentrated in Africa. What about conflict-related violence? Even with the war in Ukraine, even with all the deaths in Gaza, the majority of people that are dying from conflict-related death, it's in Africa. Who's heard about that? Haven't, right? We hear a lot of, and by the way, I am not trying to minimize the death that's occurred in Ukraine or the death that's occurred in Gaza. That matters too. Every life matters. But what's interesting is the majority of conflict-related death that's occurring in the world is occurring in Africa. Who's heard of that, right? What about workplace-related death? Where's it concentrated at? It's in Africa. And remember, a lot of these deaths are falls. Why? Again, and this is kind of getting at that principle as we go through this. I don't have to understand why something is the way it is. I just have to understand that it is the way it is. We're kind of working back from that. So it's like, this, if you think about it, this all adds up. So it makes sense. What I observed in Addis Ababa was not just a one-time thing. It just wasn't a busy trauma weekend. It's like an all-the-time thing. And it's repeated throughout Africa in other cities. Here's another kind of graph from the World Health Organization. Self-harm, you can see Africa even tops out health deaths related to self-harm. In Africa, a lot of the deaths related to self-harm are consequence of things that occur following conflict. But now let's ask this question. So why is Africa so affected by trauma? What is it? So a couple things. So here's the team that was at Abbott when we were working there. This is Dr. Natsana. She's the chairman of the department. So it's young. It's young. When I was there the first time, Dr. Natsana, who was the chairman, she was a resident working with me. So it's the youngest continent. I think the average age in Ethiopia is like 15. That is young, right? So it's young. And poverty strongly affects Africa. Of the 54 countries in Africa, 23 African nations are considered low to middle income. 23, let's see, low income. Africa has 23 member states. So if you look throughout the world in terms of continents, where low income countries are concentrated, Africa has the highest amount. So you've got a young continent, you've got a poor continent, okay? And you have a rich continent. Who thinks of Africa as rich? You have a rich continent. Africa is rich in natural resources. Just look at this. It doesn't take much to find out how rich Africa is in natural resources, both when it comes to things that are used to help with industries that have been around for a while, like copper. A lot of copper comes out of Africa, as well as things that are used to power new technologies like renewable energy. The atom bomb that was used in Hiroshima, the uranium that was used in that, came out of the Congo. And the Congo, if you look at parts of the Congo, it is the area of the world that has the richest mineral resources. Here, I just put this news article in there. Second largest diamond ever, 2,492 carats unearthed in Botswana. It's being held by that gentleman there. But it was, if you look at this, a Canadian mining company that found this, right? What am I getting at? What does this have to do with trauma? This is what's tricky about trauma. And you'll see this when you get into it. When you're treating certain diseases, be it like cardiac disease, and you can study, the pathology of atherosclerosis and what that leads to, or diabetes and how it can cause peripheral neuropathy. You've got these things that occur that, although they are linked to behavior, you could say by diet and things like that, but there's these processes that take out of it this really human communal element, if you will. But what you're going to find about when it comes to trauma is, you'll see this all the time, it really is heavily influenced by our behaviors. On an individual level, when you rotate on the trauma service and you see how substance abuse comes into trauma, but also on an international level, when it comes to how one country that may have a lot of money treats another country that is poorer. And that's what's occurring here. So if you look at this, you've got this combination here. You've got African nations with tremendous youth and human capacity, so lots of people who can work, tremendous natural resources, largely impoverished, and a desire to elevate themselves out of poverty. Who here, if they were poor, wouldn't want to elevate themselves out of poverty, right? Add that with richer nations who desire African resources, desire to use their human capacity from Africa, maybe to get those natural resources, and has the ability to make financial, political, and military investments in Africa. What do you end up with? You end up with this process called chaotic industrialization that results in rapid societal change, political unrest, and internal conflicts and proxy wars. So, what what is chaotic industrialization? And what it is, it's an imbalance in the development of various industries, right? So you looked at that skyline. There were a lot of people willing to invest in all those buildings in Addis Ababa that somehow are involved in probably, I don't know. So don't quote me on this as being correct, but they're somehow probably involved in doing business that benefits somebody in a richer nation. I don't know how much. That would be an interesting project to take each building out of that skyline and see who paid for it. But according to official statistics from Ethiopia, road traffic deaths more than doubled in the 12-year period between 2007 and 2018. This occurred during a period when its road network was more than doubled, and it plans to nearly triple its express highways over the next 10 years. Even if Ethiopia tripled its current trauma centers, it would still not have enough to serve its population adequately. You have a lot of people, other nations, China has been one of the big ones, investing in the development of roads and railways, right? Because they got to get, if you're going to have a mine, you got to get those resources out. And one thing Dr. Beza always says is the best railway in Ethiopia goes nowhere in Ethiopia. It goes straight to Djibouti, which is a port to get things out, right? And so you've got people willing to invest in the development of those roads so they can get the things out that they want, but nobody's investing in the healthcare system. And this just shows, here, if you look at, what is this? This is year. This is the number of road traffic fatalities. And you can just see how it's increased over that period of time as their roadways more than doubled. Well, with the harvesting of resources comes competition for those resources, right? If you need a particular type of mineral that you need to maintain global dominance when it comes to military technology, and a country sits on top of that, if you will, and that country maybe is loyal to somebody that is your adversary, how do you solve that problem? Well, one thing you can do is you can support a rival group who can overthrow that particular government that then becomes loyal to you. And this has recently happened in Burkina Faso. And Burkina Faso used to be loyal to the French and the Europeans, but now it's loyal to Russia. They've staged a successful revolution. And what is there in Burkina Faso? And the answer is lots of uranium and lots of gold, right? So you can see how richer nations can divide a people, pandering to the worst parts of their personality, somebody who wants to be in power and be rich, to get something from them that they want, and it destroys that culture, it destroys those people. And then how does chaotic industrialization impact occupational related injuries? Well, if you can imagine, if you're building up lots of industry and you're like, I want this diamond mine up quickly by tomorrow, people are investing in that, but you're not building up, say, the government at the same time that can have a good occupational safety administration. What you have is industries growing at a rate that's more rapid than the government to oversee the safety of these places. And you end up with very unsafe working conditions. In particular, in Ethiopia, there's one paper we quote here. It's like one in three Ethiopian workers sustain some type of significant work-related injuries. And a lot of these places, particularly mines, they're put up by rebel groups. Rebel groups will go in, take an area. Last year's fellow who worked in the Congo Andes in Zambia, his name's Dr. Kinda, this is one thing that he would talk a lot about is rebel groups will just come in, take land, they'll enslave the people, and they'll use them to mine in these illegal mines to get whatever it is they can sell to richer nations to make themselves rich. So here it is. This is what chaotic industrialization looks like. You have this beautiful skyline. It rivals Kansas City, and that's their trauma center. All these other industries are being built up, but in an unequal fashion. And in particular, what you're seeing here is you're seeing a lack of the healthcare industry being built up. So how can a university have an impact on such a huge problem? Like one of the people I talk with a lot about this are my kids. And when I go through this with them, what they'll say to me is they'll say, Dad, this is overwhelming. How am I going to affect proxy wars? How am I going to affect the development of diamond mines. How am I going to affect, China wanting to build, roadways and railways? I don't see how I can have an impact on that. All we're doing right now is just getting an understanding of this. Let's pick this apart. One thing, and I think it was Bernice Reagan that said that on there. She said, if you see something wrong and you know you need to do something about it, you need to do something about it. And it was Robert Redford that said something about, if you want to make a difference, you have to have an element of risk taking. And this, yeah, I see some of you nodding your heads. That's right. Are you just going to sit back and let this happen? Or are we going to do something about this? And what can our university do about it? So I'll show you what we came up with as we dove a little deeper into like the granular issues of this trauma epidemic. Well, what's the etiology? It's desire, right? It's desire kind of on both sides. You have people that desperately want to come out of poverty, and you have people that want their resources and they're willing to take advantage of them. Or maybe they're not willing to take advantage of them, but they don't have a thoughtful way of getting it. And in their thoughtlessness in terms of acquiring these resources, they're hurting people, quite frankly. So desire. Let's talk about what we know is occurring in the hospitals. So here was my response to my daughter when she said she was overwhelmed by this. I can't stop all these other things, but I know what I can do is we can help build up their medical system that can handle the trauma. That we can do. If they at least have the medical system to handle the trauma, we can't change these other things, but we certainly can save a lot of lives. And as you'll get more into this, you'll see that. So what do we know about trauma? Well, when it comes to trauma, fractures are the most common outcome of an injury requiring treatment. They are. Musculoskeletal injuries account for the majority of disability following trauma. 78% of injury-related disabilities are the result of a musculoskeletal extremity injury. And we also know that overall outcomes after serious trauma are good when appropriate trauma and rehabilitation care are rendered. So if we can just get them situated to where they can deliver good trauma care, they can save a lot of lives and they can change a lot of lives. What is this? This is really cheesy. At some point, if you guys stick with me, I'll have better animations, but this is something I came up with. It's a funnel. And this is, if you will, the healthcare system right now in Africa. And the bottleneck of this funnel is a well-trained surgical team in a well-designed hospital that's appropriately equipped. Because that's what they don't have right now, is they don't have the equipment, they don't have well-designed hospitals, enough of them, and they don't have enough subspecialists in these areas. So what does this blue area represent? It represents orthopedic trauma. Study out of Abbott, about 64% of the cases. So that trauma center that we work with in Ethiopia, about 64% of their cases are orthopedic trauma. About 26% are neurosurgical. About 7% are general surgical. And about 3% are other, right? So, and we've got this bottleneck. We only have so many operating rooms to get through. We only have so much equipment to treat them with. So that's what you want. You want somebody to go right through the funnel. But oftentimes what happens is, there's just this overflow. The wait list at the trauma center in Addis Ababa, Ethiopia is 5,000. It's over 5,000 patients. Dr. Basil will tell you, they'll call people back. They'll call the families to say, come back and get your surgery. And they'll call the family and the patient's died, right? So many patients don't make it through the health system. And this results in unnecessary death and disability. What determines your ability to get through the system? It's the acuity, how bad the injury is, and then chance. Were you there at a time that you could actually get into the operating room? And the irony of this system is that the higher acuity, more resource demanding, and poor outcome trauma patients are the ones that receive care. Who makes it into the operating rooms? The ones that are on the brink of death. And who are the ones that typically require the most resources and do the poorest? The ones that are on the brink of death. And who are the ones that don't make it in the operating room? The one that may have a simple ankle fracture or a simple open tibia fracture. And how do they do if you treat them surgically? Typically very well. But they can't make it in the operating room. And how do they do if they don't make it in there? Some of them die. So the irony is you have this system where the people that do the worst are beating out the people that can do the best. The people that demand the resources are getting the resources. And the people that could be treated simply and go on to live a very productive life are dying. So this is our proposal. Partner with African teaching institutions, medical companies, other nonprofits, government institutions, and faith communities to develop self-sustaining orthopedic trauma hospitals. If you do that, we can unload those trauma centers of those more simple cases, get them doing well, save their lives, improve their outcomes, and then it unloads the trauma centers to handle the higher acuity patients. And that gets us there. And that's just applying that principle. Like I said, you don't have to understand why something is the way it is. You just have to understand that it is the way it is and be willing to do something about it and work from there. So, all right, that I made it before most of you had to leave. What time do you guys got to leave? Okay, good. All right, so we have a great panel here. Dr. Abebe, Lori, Dr. Beza, Bacher. And then in addition, we have three on our medical student team here, Taylin, Annie, and Lexi. So if you guys have any questions, feel free to ask. Any thoughts, any questions? Or people from the Zoom community can ask questions.
I'm curious what your approach has been in conversation about kind of flipping that script of addressing those maybe not as acute injuries as you were talking about in your previous slide, how that's working, because we kind of live in a world where it's the worst case scenario is always sets the precedence that they get seen first. So how are you discussing kind of changing that mindset to address that?
So we've applied for a Gates Foundation grant, and that grant is proposing to use artificial intelligence to help sort these patients. Because what they have is their 5,000 person waiting list it's like a gigantic paper ledger with names on it and injuries. And so, unless somebody remembers, oh, we got an opening in the operating room today, and yesterday we sent out an ankle fracture dislocation, let's call them and get them back in. They don't have a way to kind of like do that. But with artificial intelligence, our hope is we can, link it with surrounding hospitals and then say, these hospitals have an opening and these resources to do these types of surgeries. So then when these patients come in, they can get triaged to the appropriate hospitals. So that's what we're hoping to use artificial intelligence to maximize the resources that are there. Because right now they don't even have, because they don't talk, they don't have an ability to maximize their existing resources.
Finance has to be with it too, because the ones who are able to pay out of pocket, which is the realm of rate, cannot have that care delivered. We don't always give it. I think we're talking about those individuals or patients who don't have the means to actually seek alternative areas to go and get.
Yeah.
I don't know if you're going to talk about this. Can you touch on how we could get involved as medical students?
Yeah, we'd love to have you guys involved. I mean, this whole thing happens because of you. You guys power this. There is a application that, can you speak to that, Annie? Because I don't know. Yeah.
All organizations send out applications in November and December, and so we'll probably do that again, just like we did last year. And then based on the application, there's an interview process, and then based on the interview, usually 3 years left for each year for each class.
Yeah. But we're talking about expanding it. We don't know exactly how to do that because as we grow, we need more help. Like that, we know the 3 that we bring in, there's kind of like a specific track we have them on in terms of like travel and research. But we're bringing in people from all over KU. I would encourage all of you, if you're interested, to apply to that because there's lots of work that needs to be done here. Yeah.
what are some like underlying challenges that you guys have come across that weren't expected while doing the road trips to help trauma surgery?
The most there's a couple. One is resistance to change. It happens on both sides. So, you know, as you'll see, when you start out as a young physician, the first time you have to deliver bad news to somebody like, sorry, Mrs. Smith, you have a terminal illness. There's nothing we can do. You're going to die. That hits home hard. Now do that for 15 years. You just become numb to it. And one of the most interesting things is, and Dr. Beza will tell me this, he said, the people there just don't know. They're used to death occurring as a result of trauma, and they're unaware that if you have a good medical system, these people don't have to die unnecessarily. So when you go into an area and say, hey, there's this thing that can be done and it can save lives, you'd be surprised. It's change. Think how much we like to change. We don't like to change. Even we hate change so much, even when it can positively affect someone's health, we still will resist it. So that's just, and you see that on both sides. No matter where in the world you go, you see it. And the other is getting things through human resources here. As crazy as it may sound, that is like human resources is just a challenge. Love human resources though, and how they've helped us develop this. But it just, you'll see there's challenges that you'll have throughout the process that you just didn't expect. Yeah.
I think there was a couple like obvious ones too that I think are important to know, like who we are also. So when we started teaching people, we sent them back, we kind of follow them. And one of the big things, because it seems like we've gone from like, there's this problem and here's the solution. Well, what we noticed was we teach them here and we have state-of-the-art equipment and implants and all these, resources that they go back to their home country and didn't have those. So
Such a good
one of
point.
the things that we learned right away. So we needed to help get those resources to them. That was kind of a big part of one of those things that we discovered. And then also we discovered quickly that if we're training physicians, we need to train their nursing team, and their other nurses are a big part of the whole healthcare system. Here we have nurses, radiology techs, lab, this, that, and the other, and their nurses are doing so much of everything. So if nurses aren't trained, that system breaks down pretty quickly. So those are two really big things that we learned also.
So true.
A little bit more kind of obvious, but that we had to kind of fix along the line.
Yeah, it's almost universal. People can get, through the internet, they can see what a hospital looks like in America. But it's so interesting when they actually come here. That group I showed you, Dr. Solomon and Dr. Abebe, and they said, just train us and we'll be fine. But then when they got here, they said, whoa, training's not enough. Like we had no idea we needed so much in terms of resources. So yeah, you discover these things. You take one step and then you find something else you have to do. Yeah.
Could you speak a little to the impact the fellowship program has had? If we have any
What do you think, Dr. Beza? I think that's really good. Dr. Beza is a residency program director at Abbott, and he's seen some fellows come back. What do you think the impact of the fellowship is?
I think it's kind of teach you a lot of stuff that you didn't know before. So me being here, had the opportunity to learn some complex trauma things, how to solve them from the trauma surgeons here. And also me having this knowledge and practice is going to help me, and I'm going to teach a lot of people back home. So I'm going to share my knowledge and practice, and also me knowing, experiencing the technology that you have here is going to help me even in building this technology whenever I go back home, because that's the thing. When Dr. Solomon and Dr. Ravi came here, they say they were learning. At the same time, they were seeing this technology and say, well, we need this stuff.
and I think it's going to do a lot of impact, mostly in teaching. At the same time, there are a lot of people who are just taking services here, so it will impact in both ways.
Yeah, so when you train a fellow, you just don't train one person. How many residents do you train a year?
Like we have like 4 or something.
Yeah, huge impact.
First, second, third, and fourth.
Yeah. You guys were a part of that. Yeah.
I had a question on more of a macro scale. I think a lot of times that we see like America versus like more Western nation perspective, we compare us to like NATO organizations, like the World Health Organization. A lot of countries are involved in that, and you mentioned Canada as one of them that profits in Ethiopia from the Ethiopian like resources. How do we encourage countries that are close to America but are not America, not involved in their own government, to take accountability? I've seen a few videos that have been put out on the internet and like a more like global initiative to kind of give back to some of these developing countries that we've taken advantage of historically. But what do you think that narrative is going to look like for the next 10, 20 years, being very involved in that, or anyone on the panel?
That's the whole point of the documentary, to raise awareness and social consciousness regarding this cause. Yeah.
Yeah, right now we have a documentary that's screening a couple times locally. We're doing the first international screening next month for the festival. We've also been doing social media, which has
In the United Kingdom, right?
Yeah.
Yeah,
and
in the
some
United
of the-
Kingdom.
Yeah, some of the social media posts have done really well to an Ethiopian audience, where it's even had impact on their hospital system. Things have been exposed. So
Thanks, everybody.
I think a lot of it is just just like you said, you're watching videos of raising awareness, showing more people the people in the democracy here, really the power to get them.
What is something that I can get excited about? Sounds like a material impact that I can see. Like, what can I get excited about specifically?
We had two students, or several students, do what I consider landmark articles that just got accepted for publication. And they're landmark articles in that they demonstrate the lack of resources for the treating of trauma care. One in Ethiopia, where we couldn't necessarily get at the data showing that they're turning people away, because it was just hard to get the institution to give us that information. All right, because I mean that makes their institution look bad, and particularly when it's a public institution, it can make the government look bad. So what we did was we did a workflow study. So we just interviewed physicians and we said, tell me your workflow when somebody comes into the ER. And so and what they did was they said, well, a trauma patient comes into the ER, and then we see if we have this. And what if you don't have that resource? Then we send them home. It's just, yeah. Yeah. And so we had the trauma physicians do that, and we don't have the numbers, but by putting that workflow out there, it shows they don't have the resources and they're turning people away. And then in Zambia, Laura Jackson worked at this for like 4 years. She did a public hospital versus private hospital analysis of outcomes with respect to trauma. And what that showed was that the majority of patients leaving, having received trauma care in a public hospital, the majority end up with some type of complication. So even they're not getting treated as they should, in terms of like there are people getting turned away. And then the ones that are getting treated, they're having complications. And we just looked at 4 complications. So one of them being infection, neurologic injury, return to the operating room, and the fracture not healing. Why does that matter? Here's why it matters. In particular, Zambia is very sensitive to this. 1 in 3 people died during the heights of the AIDS epidemic in Zambia, 1 in 3. And a lot of the AIDS was being spread through the public hospitals where people were going to help. They were going for help, but they were reusing needles and things like this. And they were making the epidemic worse, right? And it wasn't until that was recognized that they could turn that around. What's happening now with the trauma epidemic? Well, in some respects, we're making it worse at these public hospitals. It's the same thing all over again, but with a different type of problem. So Those studies have a huge impact. Now, just like you saw with Alexander Fleming and the discovery of penicillin, sometimes you can publish a landmark article and it doesn't have an impact till 10 years later, right? But I'm telling you, there's a lot of good research that's being done right now in terms of like telling this story of trauma in Africa and how it's driven by the desire of richer nations, you know, and you know, it's also, like I said, there's this desire to come out of poverty on the African side too, but just we need a more thoughtful response to this. So there's lots of good research to be done. Yep.
Also, just from like the medical student perspective, what started to really draw me in was seeing how well people experience this. I think in a lot of research, you kind of just have like the potentially like surgeon and then the medical student, but here it's like you have the nurses, you have the fellows, you have media people, like you're seeing like, okay, how can we, like, why do we all need to come together to actually make a change? And I think it makes it much more sustainable in the approach that ATI is taking, and it's something that I've really enjoyed being part of. And I think like something else to consider is it's not that you can only do one type of research. Dr. Headings is very willing to work with us on any kind of research. I'm really interested in the global health side of all of it. Like, okay, how can we take this beyond just the places that we're looking at right now? So you kind of get to like use your brain in any way that you're wanting to, and it really allows you to explore it. So that's like, and like going to meetings each week and seeing, okay, how much work does this actually take? I love it.
Yeah, you got to be a self-starter, and you kind of, in many respects, get to be your own boss. So I'm too busy to micromanage you. Yeah, but I'll get behind you. We'll come up with a plan, and I'll get behind you, and get you going. Yeah.
And I don't really know. Sorry. To keep on.
Yeah.
I don't really know many leaders that are as supportive as us.
Thank you, Talon. All right. Well, thank you all for coming. Really appreciate it.
Yeah.
Yeah, thanks so much.